Great. So welcome again, welcome everybody. Thanks for being here early in the morning. Appreciate it. I think we're all really interested in this topic and very excited to have Dr. Brewer here to present for us. So we'll get started. We'll let him take it away, but let me introduce who he is, and I will actually go through a couple things quickly too. I did mute everybody just so that we don't have any background noise. So if you do need to speak, you can unmute yourself on your phone or on the computer, and then we'll be able to hear you. But as we're going, if you have questions for Dr. Brewer, please just feel free to put those in the chat, and we can raise those to him as we go along. So I'm Martha. I'm the Public Health Research Associate at LABBN, and then we also have Terry here, who is the training coordinator at LABBN. I'm sure many of you have worked with her, and she and I will both be monitoring the chat as we go through. So we'll make sure your questions get raised to Dr. Brewer. So once again, welcome, and we're really interested and excited to have Dr. Brewer here. So I'll introduce him, then I'll let him take it away. So Dr. Timothy Brewer is a professor in the Division of Infectious Disease at the David Geffen School of Medicine at UCLA, and is a professor of epidemiology at the UCLA Fielding School of Public Health. He is an authority on using analytic methods to optimize the population-based control of infectious diseases, particularly tuberculosis and HIV/AIDS. He has extensive experience developing and overseeing training, education, and service programs both locally and in countries around the world, and has received multiple teaching awards for his efforts. Dr. Brewer has served on advisory boards and review panels for numerous international and national organizations, including the World Health Organization, the National Institutes of Health, the U.S. Centers for Disease Control and Prevention, and the Canadian Institute of Health Research. He currently serves as chair of the board of directors for the Consortium of Universities for Global Health. So please join me in a very silent but very excited warm welcome of Dr. Brewer as he presents this webinar titled Preventing Pandemics in an Interconnected World, the COVID-19 Story. Thank you, Dr. Brewer, for being here, and we're very interested in this. So I will let you unmute yourself and take it away from here. Or I will unmute you myself. Let's see.
Okay.
There we go.
Thank you.
Yeah.
Thank you very much for having me, and thank you, Martha, for the lovely introduction. So I'm going to run through COVID-19 and talk a little bit about pandemics. It's a topic I find very fascinating. I hope you will too. We all have challenges from working at home. One challenge that I have is I have a very large dog whose job it is to protect the house from squirrels, birds, delivery people, and other random things that happen outside. So I apologize in advance if all of a sudden you hear large, loud barking. It is not me, it is my dog saving me from God knows what. So what we're going to do today is we're just going to run through pandemics. I'm going to talk a little bit about why they happen, and then I'm going to talk a little bit about what the World Health Organization in particular does to try to control pandemics, and then we'll jump into the specifics of COVID-19. And I don't know, Martha, if it's easier to hold questions till the end or you want to let people jump in, but I'm happy to do whatever. Also, can you just let me know, can you see my mouse? I don't actually seem to see my mouse, but I would point at things with my mouse if people can actually see it.
Yes, so we can see your mouse when you move it around. So if you use that. And I think we can keep questions for the end unless there's something that seems really relevant to what you're going through. But that way then everybody can just keep, but as you're going, we'll have people type them in. I'll just keep track of them.
Terrific. All right, so the first thing I want to say is just outbreaks happen all the time, right? So we're in the middle of COVID-19, but as you can see from this chart, we've had a number of outbreaks in the last 2 decades, and actually we'll talk a little bit about going back earlier in time. I think the relevant ones for today, so we all remember the SARS outbreak, another coronavirus. This was actually the first coronavirus outbreak to cause a major health emergency and actually led to changes in international health regulations that I'm going to talk about in a little bit. Just to remind us, SARS was about 8,000 cases around the world, a little under 800 deaths, so a case fatality rate of about 10%. But we can see that there's been chikungunya. We probably all remember Zika. Zika's still out there. It's still circulating. We tend not to think about it. But again, we could see a flare going forward. The last pandemic that we had was actually H1N1, and that was discovered in March of 2009 in Mexico, spread through until April of 2010, but is actually continuing to circulate to this day. So the predominant H1N1 virus, influenza virus, circulating in the world today is that pandemic virus that first showed up in 2009. And in fact, if you were born before 1968, you've actually survived two pandemics. So we did have a pandemic in 1968 as well. That was another influenza pandemic. And people may say, well, gee, what was the big deal? If that's a pandemic, who cares? Well, the big deal was that it's estimated that about 60 million Americans got infected with that virus between March of 2009 and April of 2010. If that virus, that H1N1 virus, had the same case fatality rate as the current COVID-19 virus that's circulating in the United States right now, that would have translated to approximately 2.4 million Americans dying in 1 year. And so that gives you a sense of why these pandemics can be so serious. So the first question is, are emerging diseases actually emerging, and are we seeing more and more of these? And there have been a number of studies to look at that. And really just what I want to show you from these graphs is that in general, it looks like the trends are going up. And so this is emerging diseases by the type of pathogen, whether it's a bacteria or a virus or a fungus or a parasite. The one below it, the black and white one below it, is just bacteria as to whether or not they're drug resistant or not. But the important thing is that a majority of these events are zoonoses. That means that these are infections that originally exist in animals and somehow have managed to jump a species barrier and get into humans and then cause disease. And in fact, that's going to be critical when we talk about SARS-CoV-2, which is the virus, or COVID-19, which is the disease, because we believe that SARS-CoV-2 is also a zoonotic pathogen, that it started in an animal and then jumped into humans. This is a little confusing, but I just want to focus on a couple of things. The issue is here that there are a lot of diseases that we now recognize as emerging diseases, but I want to really focus on a particular type. So the first example of an emerging disease is Helicobacter pylori. So when I was a medical student back in the 1980s, I was taught that gastric ulcers are caused by stress, by coffee, by cigarette smoking, by alcohol. And the way to treat it was to put people on antacids, or then we got a medicine called cimetidine. And really, you were going to put them on this medicine for the rest of their life. And then lo and behold, two Australians, Robert Warren and Barry Marshall, in fact, showed that gastric ulcers are caused by a bacterial infection. So that's one kind of emerging disease. a disease where we didn't realize it was caused by a pathogen, and then we figured that out. The second type that I want to highlight is parvovirus, and I think most of you are nurses and take care of children and babies, so you're probably very familiar with parvovirus. This is slap cheek disease or fifth disease. This is one of the viral exanthems of children, and this is a disease that doctors and nurses have known about for over a century, right? So fifth disease was really originally described in the 1800s, and they knew it was an infection. They just didn't know that it was caused by parvovirus B19. And so a second example of an emerging disease is the fact that we now have technology that allows us to recognize infections that we did not realize or have the technology to recognize before. But really, what I want to focus on are these diseases that start off in animals and jump into people. And the prototype is actually human immunodeficiency virus, or HIV. So HIV was originally a monkey virus. And then this monkey virus managed to get from monkeys into great apes, particularly chimpanzees, and then to get from great apes into humans. And we think that happened sometime in the early 20th century. So sometime in the 1920s, 30s, 40s, around then, this virus managed to get from great apes into humans and eventually caused what we now recognize as the HIV/AIDS pandemic, and that's the prototype of zoonotic infection. These viruses can be spread by person-to-person contact, such as the case of HIV. They can be spread by vectors. So Zika virus, for example, which we talked about briefly earlier, is originally also a monkey virus, spread by mosquitoes, managed to get into people. Or they can be spread by coughing, sneezing, talking, as in respiratory viruses. And of course, influenza and coronaviruses are two examples of those. So why do we care about them? Well, I probably don't need to show this slide anymore, but when I used to talk about pandemics and outbreaks, people would say, you know, who cares? H1N1 wasn't so bad. Well, one of the reasons why we care is obviously these outbreaks and pandemics can have tremendous economic consequences, and we're certainly seeing that. Unfortunately, today we're seeing the tragic fallout of what can happen when you have an infectious disease outbreak on an economy. And so I won't really dwell on that further, but you can get a sense of how these outbreaks can really cause severe economic disruption. So for example, the bovine spongiform encephalopathy outbreak in the United States and Canada actually had no human cases. That was 6 cows, but 6 cows having a disease was sufficient to cause over $6 billion in losses to the American and Canadian cattle and beef markets. So where do these things happen? And the short answer is everywhere. And what I really want you to do is focus on the bottom set of the globe. So you see all these dots up here on the top. These are outbreaks of emerging diseases that had occurred within the last 2 decades when this article was published in 2008. But I want you to look down at the bottom where there are many fewer dots. So this dot right here, this dot is actually, they call it gray pox, but that's syphilis right at the bottom of France there. And so what happened in 1493 is in 1492, Europeans got on boats, they sailed across the ocean, they went to what they called the New World, but in fact had been around there as long as Europe. And they came in contact with the indigenous populations and acquired an infection, a treponema infection, Yaws-like infection that they then brought back to Europe and created what we now know as syphilis they also brought over with them smallpox. And so you see a dot or a little square over on the other side where the introduction of smallpox is. The square up in the middle of Asia there is actually plague. And so when the Mongols moved through Southeast Asia and intra-Central Asia, not only did they bring with them technology, for example, stirrups. So part of the reason why the Mongols were so successful is they had invented stirrups that allowed them to stay balanced on horses. But they also brought with them rats and fleas and Yersinia pestis. And that was the first of a series of waves of what became known as plague or Black Death. And so the point being that while we think of these emerging disease problems as relatively new or recent problems, they've been in fact happening for decades. And I'll talk a little bit about why that is. And so that's because part of why these outbreaks occur is because of things we do as humans. And one of the things that we do as humans is we move around. And so we tend to migrate and travel. And as we do that, we tend to bring things with us, some which we plan to, and some like rats, fleas, and Yersinia pestis that we don't necessarily plan to bring with us. The other thing we do is we change our environment. So we change habitats, we drain land, we cut down forests, we plow fields, and altering that environment brings us into contact with organisms that we may or may not have come into contact with before. And I'll run through a couple of examples of how that can happen. The other thing that happens is our environment is changing more broadly because of things that we're doing. And the big example of that, of course, is global climate change. And so temperatures are rising. That allows vectors like ticks to live and move in new areas where they didn't exist before. We now have mosquito species that exist in places where they didn't exist before. All of those things will affect the likelihood of an infection spreading. And then finally, our conditions are changing. So about 2 years ago, we passed a milestone in human history where we had more people living in urban areas than living in rural areas. So for the first time in human history, there were more people living in cities than there were living out in the country. And now we have these giant mega cities. Mexico City is over 20 million people. The greater Tokyo area is over 25 million people. Wuhan, which we've all learned about from COVID-19, is 11 million people. So we have these very large, densely populated cities. For example, in Manila in the Philippines, Manila has 41,000 people per square kilometer. So just amazingly dense, highly congested cities, and that facilitates the transmission of infectious diseases. We also have increasing social inequality, we have poverty, and so you have people living in very crowded places that don't necessarily have access to things like water, soap, sanitation facilities, clean air. All of that can contribute to an outbreak occurring. So let's run through a couple of outbreaks just to get a sense of how these factors may play. And I'm purposely choosing some outbreaks from the past just to remind us that this is not a new phenomena, we're just more familiar with it. So what you're looking at now is Harper's Magazine, and this is Teddy Roosevelt standing next to Uncle Sam, and you can see we're in Panama, and we have this mountain here with vultures, and it says yellow jack. Well, yellow jack is yellow fever, and what's going on here is the building of the Panama Canal. So the French actually tried to build the Panama Canal, and I'm sorry. Hey, quiet. Sorry, that's some imaginary creature out there, no doubt, storming my house. So, so what happened when the French tried to build the Panama Canal is they went into this virgin tropical forest about 47 miles from the Pacific Ocean to the Atlantic Ocean to dig a canal, but it's actually very mountainous, full of mosquitoes, not full of people. But unfortunately, those mosquitoes carried both malaria and yellow fever, and the French ended up losing about 1/3 of their entire workforce to malaria and yellow fever. And if you ever get a chance to visit Panama, if you go and you visit the Panama Canal, you will see these little graves where they have crosses for the people who died. What they don't tell you unless you go read the little signs is each one of those crosses actually represents 100 people dying. So multiply what you see by 100 to get a sense of how many people died. So when the United States built the Panama Canal, we were successful not because we had better engineers than the French, but because Colonel Gorgas, who had demonstrated that mosquito control programs could eliminate yellow fever and malaria in Cuba, in Havana, was brought in to do exactly the same thing in Panama. And so they managed to essentially eliminate yellow fever deaths and reduce malaria deaths by about 90%. And that was the reason that we were successful in building the Panama Canal. You probably have all heard about Middle East Respiratory Syndrome, or MERS coronavirus, the second of the 3 coronaviruses that we're going to talk about today. And this picture is just to remind you 2 things. One is, if you happen to own a camel, please do not kiss your camel. But the broader picture points out to the fact that we intimately live with animals. So you probably are now all aware that I own a dog. I suspect many of you own dogs, cats, or other domestic animals as well. And those animals all carry their own viruses and other organisms. And it's possible for those organisms to get from animals into people. So that's a zoonotic infection, and then lead to disease. So the MERS coronavirus actually began in bats, managed to get from bats into camels, and then to spread from camels to people, and is actually continuing to have outbreaks. Fortunately, MERS is not very contagious person to person, because the mortality, the case fatality rate for MERS is about 34%. So it's about 6 times higher than the COVID-19 case fatality rate. So fortunately, this virus has not adapted to spread well from person to person, but does exist within dromedary camels, and there are continuing cases occurring in places where people and camels are interacting. So let's bring those 3 together to talk about another virus. This is the Knipper virus. So these are flying foxes. Flying foxes are fruit bats, and they exist throughout the tropics, starting in northern Australia, all through Southeast Asia, traveling in an arc all the way over to Madagascar. And in general, they tend to live deep in tropical forests, far away from people. They also happen to be the natural host for a virus called Nipah virus. So what happened in Malaysia is that they went up into the middle of the forest, they cut down a bunch of trees, and they built these giant pig farms. Because in Malaysia, if you go within several hours of Malaysia, you're talking about a population of about 500 million people with a huge demand for pork. So they went out into the middle of the jungle, mowed down the jungle, and started building pig farms. Unfortunately, what they were doing was disturbing the natural habitat of these flying foxes. The other thing that they did as a way to augment their income is they planted fruit trees, particularly mango trees, around these pig farms. So the flying foxes came to feed on the fruit, and they would then defecate, and pieces of the fruit and the guano would then drop to the ground where the pigs would then eat them. This created a disease called barking pig. So the pigs actually got a respiratory infection. They would cough and it made kind of a barking sound. And then that led to encephalitis in humans. And so it was a virus that got from bats into pigs into people. And the way that they ended up controlling this outbreak was actually slaughtering all the pigs. So they interrupted the chain of transmission, killed over 100 million pigs to stop this outbreak. But before it did, they ended up having almost 300 cases of encephalitis, 100 deaths, a 40% mortality rate. And just another example about how a virus which lives in a host, in this case a flying fox, where it's not causing any problems, can jump a species barrier, get into people, and then create an outbreak. So I mentioned one of the things we've done is we've moved things all around the world. One of the things that we've moved unintentionally are mosquitoes. And so what you're looking at is Aedes albopicus. Aedes albopicus is the East Asian tiger mosquito. And this mosquito is actually supposed to live in Malaysia and nowhere else. And down here in parts of Malaysia, Thailand, and not really anywhere else. But because of the used tire trade, we've actually disseminated this mosquito all around the world. Now, this happens to be a female mosquito, and I know that because it's actually only female mosquitoes that transmit disease, because female mosquitoes need to take a blood meal in order to ovulate. Male mosquitoes are actually vegetarians. And so unfortunately, it's the females that create the problems when it comes to mosquitoes, unlike just about every other species, where it's usually the males that are creating all the problems. But we have now disseminated, this mosquito is now endemic throughout the world, and this is a very good transmitter of a variety of viral infections, including dengue, Zika, chikungunya. The other mosquitoes, Aedes aegypti, which has also been distributed around the world, is actually the most efficient vector for transmitting these infections. So we've taken these mosquitoes, Aedes aegypti is supposed to live only here, and Aedes albopicus just here, and we've spread them around the world and allowed them to then be able to disseminate infections across human populations when those viruses get introduced. So how do we do this? One of the things we do is we travel, right? And as of last year, about 1.4 billion people traveled around the world, and that's just tourists. And so if you include everybody traveling, it's probably more. The important thing to remember is you can now get anywhere in the world within the incubation period of just about any infection, right? So how did we use to prevent infections in the old days? One of the things we did was we quarantined people. We said, no, you have to wait on the ship outside of the Venice harbor for 40 days. That's where the word quarantine comes from, so that you don't bring plague or whatever else into Venice when you come in. But when you can get halfway around the world in under 20 hours, you can understand how easily these pathogens can move, and COVID-19 is actually a terrific example about that. And we'll talk a little bit more about that in a second. So when do we worry about these things? Well, one of the reasons we worry about them is when it's a new disease. So COVID-19 was first discovered in December 2019 and was actually picked up because the Chinese have a program in place to look for pneumonias of unknown etiology. And that's exactly what happened. In Wuhan, they started seeing people being admitted to the hospital, generally men, generally older, having pneumonias, and they did not know what the cause of the pneumonia was. Because of the SARS outbreak in 2002, 2003 in China, they actually had a program in place to do genomic screening to look for new pathogens, particularly coronaviruses. And they did a screen looking for new pathogens, and lo and behold, they found a new coronavirus that we now know as SARS-CoV-2 or COVID-19. So that's one reason we get worried about outbreaks, is when it's some pathogen we haven't seen before. Second is when they can spread internationally. Third, internationally, when you have serious illness or death, when they interfere with international trade, and bioterrorism. And COVID-19 is checking all of these boxes, right? So not surprisingly, it is a pathogen of international concern. So how do we actually go about dealing with these pathogens as a society globally? So the framework that we use is something called the International Health Regulations, and they actually came into play because of the SARS outbreak in 2002, 2003. So before SARS, there were actually only 3 reportable diseases, 3 diseases that governments had to tell the World Health Organization about if they had an outbreak. And those 3 diseases were yellow fever, cholera, and plague. So if you had an outbreak of any of those 3 diseases, you needed to notify the World Health Organization. But an outbreak of anything else, you didn't have to tell WHO if you didn't want to. And that's exactly what happened with SARS. So we now know that SARS was circulating in China in the fall of 2002, but it wasn't until February and March of 2003 that there was any public announcement about the fact that SARS was existing. So because of what happened with SARS, countries got together and they ended up adopting a new set of international health regulations that now require countries to report any public health threats. So any illness or medical condition, it doesn't need to be an infection, that could present or represent significant harm to humans, now needs to be reported to the World Health Organization. And if the WHO feels that this concern rises to a certain level, they then can create what is called a public health emergency of international concern. And we have had 5 public health emergencies of international concern since these regulations went into effect in 2007. The most recent one, obviously, being COVID-19. So COVID-19 was first declared a public health emergency of international concern in mid-January, and then in the end of January, I believe it was January 31st, was actually declared a pandemic by the World Health Organization. So this is the framework that we use to try to control outbreaks and pandemics when they actually occur. So I just want to take you through one other outbreak just to try to tie this all together before we dive into COVID-19. And to do that, I'm going to pick another virus, West Nile virus. So West Nile virus is a flavivirus. Like coronavirus, it's a single-stranded RNA virus, but unlike coronavirus, West Nile is spread by mosquitoes. So it's a mosquito-borne virus, originally described in Uganda in 1937, hence the name West Nile. It was named after where it was found. And the first cases were reported in America in the summer of 1999. So how does a virus get from Uganda into Queens, New York in the summer of 1999? And to understand that, we have to go back a little bit in time and talk about birds. So this guy up here in the corner is a crow, and you guys are probably all familiar with American crows. This is the American crow. American crows are very interesting birds. One of the features of them is they're highly intelligent for birds, and the second is they're very gregarious. So they tend to get together in big groups, usually at 5 o'clock in the morning, and they make a racket, right? Blah, 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 blah. They get on the little crowberries and they start talking to each other about dead squirrels or garbage or whatever else the crows want to talk about, make a big noise. So most people think of crows as pests. So in the summer of 1999, when crows in New York City and surrounding New York started dying, nobody cared, right? So these crows would drop out of trees and people would be like, oh, it's raining crows. But nobody asked the question, why are the crows dying? Because they didn't care about crows. Crows were pests. Meanwhile, over in Queens, New York, two older gentlemen developed encephalitis and they died. Well, old men die, we see that, that's unfortunate. A very astute infectious disease physician reported these two encephalitis cases to the New York City Department of Public Health, and she said, gee, you know, pretty unusual to see two cases of encephalitis so close together. And the New York City Department of Public Health said, gee, maybe we're having an Eastern equine virus outbreak. Maybe we need to spray for mosquitoes. But again, they didn't pursue it any further. Old men die, that's too bad. We don't care too much. Meanwhile, over in the Bronx, this is the entrance to the World Zoologic Gardens, or what I knew growing up as the Bronx Zoo. In the Bronx Zoo, Chilean flamingos were keeling over and dying. And unlike crows and old men, when a Chilean flamingo keels over and dies, somebody wants to know why. So they actually did necropsies on these flamingos. They found that they died of viral infection. They actually cultured the virus, and then they actually sent the virus to the CDC for whole genome sequencing. And this was actually a very big deal in 1999. It's not like today where you can get whole genome sequencing at Best Buy or In-N-Out Burger, right? This was a major deal to get whole genome sequencing done. And they found that, in fact, these flamingos had died of West Nile virus. And the question became, how did West Nile virus, which had never been reported in the Western Hemisphere before, end up in Chilean flamingos in the Bronx Zoo? And not only was it West Nile virus, but essentially the same sequence as an isolate from a goose in Israel that had died the year before, where they identified West Nile virus. So all of a sudden you had these very smart people talking about how maybe Egyptian geese, because there's actually no species of Israeli goose, it's actually an Egyptian goose, which have been migrating between Africa and Europe for millennia, making wrong turns and landing in the United States. But the problem with that was no one had found any Egyptian geese in the United States. But what we do know is that in Israel at the time, there was an outbreak of West Nile virus going on. So a very large outbreak of West Nile virus in the summer of 1999. And we also know that every single day, a 747 takes off from Tel Aviv and lands, of all places, in Queens, New York, exactly where the outbreak started, and the first two cases of encephalitis were found. And while we don't know for certain, we assume what happened was that people infected with West Nile virus flew to New York. Mosquitoes then bit those individuals, because actually, even though you get a very high viremia from West Nile virus, only about 1 in 150 people infected with West Nile virus actually get sick from West Nile virus. then those mosquitoes introduced it into the crow population. Unfortunately for the crows, West Nile virus was fatal. That's why the crows were dying. Got amplified in the crows and then spread via mosquitoes to other animals and people. And so I just want to show you what happens when an infection is introduced into a susceptible population. So it took about 4 years for West Nile to become endemic across the entire United States. So this is an infection that never existed before 1999 and now will never go away. And we have cases of West Nile now every single year here in Los Angeles, as they do in many other places around the world. And we're seeing exactly the same thing play out now with COVID-19. We're watching an infection spread through a susceptible population around the entire world. All right, so just to summarize this first part, outbreaks are happening all the time. We're better at recognizing them and reporting them, but they're also happening because of a lot of things we do, like changes to our environment, rapidly moving things around the world, living in more densely packed cities, and the fact that we have millions and billions of people around the world living in poverty. All of those contribute to these outbreaks occurring. So now let's turn to coronavirus and COVID-19. So this is a coronavirus. And if you look at an actual picture of a virus under an electron microscope, you see these kind of spike proteins, as they're called, around the outside, and that's where the name comes from. So corona just means crown, kind of looks like the virus is wearing a crown. These are large single-stranded RNA viruses. So measles is an RNA virus, influenza, Zika, as I mentioned. All of these are RNA viruses, but coronaviruses are actually larger than most of them. So for example, coronavirus is about 3 times bigger in terms of its genome than a typical influenza virus. There are 4 types of coronavirus: alpha, beta, gamma, and delta, 2 of which, alpha and beta coronaviruses, cause infections in mammals. So these are not just infections in people, these are also viruses that cause infections in animals as well, and they're in fact naturally animal viruses, some of which have managed to jump into people, which we'll talk about. They tend to cause gastroenteritis in animals, and there's a very serious outbreak of swine gastroenteritis coronavirus going on around the world right now, severely impacting pork production. And they tend to cause respiratory tract infections in humans. So as I mentioned, these are all zoonoses originally, which means they start in animals. And almost all of the coronaviruses tend to start in bats. Bats are the natural reservoir for most coronaviruses. And right now, there are 7 coronaviruses that we know infect humans. 4 of these coronaviruses, the top 4 up here, 2 originally started in bats, 2 originally started in rodents, but now are endemic in humans. They tend to cause mild upper respiratory tract infections. They do not tend to cause serious disease, though they can, particularly in neonates and young children and people who are immunocompromised. These are coronaviruses that we've known about for decades and really haven't been paying any attention to. The first major coronavirus outbreak that we all heard about that led to serious disease in humans was the SARS coronavirus. This is a beta coronavirus, and that happened in 2002. Went through, we believe, an animal called a palm civet or civet cat. So went from bats to palm civets into human. Fortunately, only contagious in people who were very sick. That's why we tended to see outbreaks in hospitals more than in communities. and that helped to facilitate the control of that outbreak, bring it to an end after about 8,000 cases. The second one that we recognize is the Middle Eastern one, the MERS coronavirus, which I mentioned is still out in dromedary camels. So went from bats to camels to people. Again, very fortunate that did not easily transmit to person because of the 3 coronaviruses. This is actually the most virulent. The mortality rate, as I mentioned, about 34%. So very serious infection. Fortunately, does not transmit easily from person to person, but there have been outbreaks in hospital, so some limited person-to-person spread. And then the last one is the new SARS-CoV-2. So the COVID-19 coronavirus is about 80% similar to the SARS coronavirus. They both bind to the same receptor within humans, the angiotensin converted enzyme 2 receptor, which unfortunately is widely distributed throughout the human body. It's found in epithelial cells in the lung, in the upper respiratory tract. It's found in myocytes in the heart, endovascular endothelium in kidneys and liver. So when these viruses get into the body, there are a lot of tissues that they can enter. And unfortunately, COVID-19 or SARS-CoV-2 virus binds with a much higher affinity than the SARS coronavirus did. So it binds about 10 times more tightly to the receptor than the SARS coronavirus, and that probably helps to facilitate its transmission. So far, we do not know what the intermediate animal host was. So some people think maybe it was a pangolin, a kind of anteater-like animal, but we don't actually know. But we do think that the original host were bats because the SARS-CoV-2 virus is most closely related to 2 different bat viruses found in horseshoe bats in China. So how does the coronavirus actually get into a person? What it does is it binds to the receptor, in this case, the ACE2 receptor, though there may be a co-receptor involved as well. That's still being worked out. And then typical of RNA viruses, what happens is the RNA actually has to get transcribed and translated back into DNA, where it's then used to make proteins. Those proteins then combine with vesicles to create new virus particles that are eventually released. And pretty much every RNA virus follows a similar cycle. One of the challenges of treating viral infections is because they use the host cell's machinery to replicate, if you're using medicines to try and interrupt the cycle, these medicines can potentially be toxic to the host cells as well, because if you're trying to block these cycles, what you may be blocking is a natural host cell mechanism. And so that's one of the challenges of finding treatments for RNA viruses. And so one of the things we do is we try to target steps in the replication cycle that are specific to the virus. Probably the best example of that is the medicines that we now have available to treat HIV, human immunodeficiency virus. So again, if you think about the different antiretroviral medicines that we have medicines that try to block transcription. So those are things like our nucleotides, tenofovir, lamivudine, things like that. We have medicines that try to block protein formation, our protease inhibitors. We have medicines that try to block the receptors, the CCR5 blocker. So essentially what we try to do when we're treating viral infections is we look at those steps in the life cycle where we can potentially interrupt the life cycle without damaging the host cell. And we'll come back to that when we talk about treatments potentially for COVID-19. So what do we know about COVID-19? As I mentioned, first described in December in Wuhan, Most of the cases initially were associated with exposure to a live animal seafood market in Wuhan, and then very rapidly spread from there around China before disseminating to the rest of the world. At least initially, they tended to be quite severely ill. About 16% of people were sick enough to require hospitalization, and the case fatality rate initially, when it was first recognized, was about 1.5%. You can actually isolate virus from a lot of different body fluids. So virus has been found in respiratory secretions, it's been found in saliva, it's been found in stool, and it's actually been found in blood as well. But we think that really respiratory secretions are the only important body fluid for transmission, and I'll come back to that in 1 second. So coronaviruses are respiratory droplet infection spread. What do I mean by that? So when we cough, sneeze, or talk, we're producing little droplets of mucus and fluid that get spread out into the air. If these droplets are larger than about 5 microns in size, we call them respiratory droplets. They tend to travel in the range of 3 to 6 feet, and then because of their size and weight, impact on surfaces by gravity. In contrast, infections that are spread by what's called airborne transmission, so that would include tuberculosis, measles, and varicella, tend to produce droplets that are less than 5 microns in size. And so those droplets, because they're so light, they can actually remain floating in the air for extended periods of time. And then if you were to walk into that environment and breathe those droplets in, you could acquire the infection. And so that's the difference between an airborne transmission or aerosol transmission and a respiratory droplet transmission. Now, obviously, people produce both kinds of droplets, but it's the primary droplet we believe for COVID-19 and coronaviruses are these larger respiratory droplets, which means that you need to be in relatively close contact with someone in the range of 3 to 6 feet. And if those droplets get on you or they land on your mouth or nose, you become infected. The other way you can become infected is those droplets can land on a surface. You can touch that surface and then touch your mouth or nose and acquire infection that way. And we know that these viruses can survive on surfaces for up to days, but in general, they tend to die rather quickly once they land on surfaces. But all of this will come into play when we talk about prevention and control and disinfectants and hand washing and masks. It's all about dealing with how we understand SARS-CoV-2 to be transmitted. One of the things we have learned is asymptomatic and pre-symptomatic transmission occurs. What that means is that people who are infected with the virus have high virus levels but no symptoms are then capable of spreading that virus to other individuals even before they're symptomatic. And that's actually true of influenza as well. You're actually contagious with influenza before you have active disease. And that's part of what makes these viruses so difficult to contain. This is also different than what happened with MERS and SARS, the two previous serious coronavirus outbreaks that we had. So SARS really tended to only be contagious in people who were very sick, and that helped to facilitate its control. So SARS-CoV-2 is behaving differently than SARS, that we're seeing asymptomatic and mildly symptomatic transmission of disease. Where do we stand as of yesterday? Just under 4 million cases. I think we're over 4 million cases today, about 275,000 deaths around the world, a case fatality rate of about 7%, and that's been creeping up. You remember the initial study I showed you from the New England Journal of Medicine, they reported a case fatality rate of about 1.5%. Globally right now, it's running about 7% and varies greatly from country to country. Here in the United States, we have about 1.3 million cases. So 1 out of every 3 SARS-CoV-2 cases in the world has occurred in the United States. So far and away, the most cases have occurred here, and that's not just because of testing. Actually, we do less per capita testing than a number of countries like New Zealand, Italy, Taiwan. It's just, we unfortunately have both a large population and we're having a large outbreak. Our case fatality rate nationally is running about 6%. I'll talk a little bit more about who's dying a little later on. Here in California, we're running at about a 4% case fatality rate. In Los Angeles, a little bit higher, almost 5%. And about half of all the cases in California are occurring in Los Angeles County. So the incubation period is anywhere from 1 to 14 days, but we think on average is about 5 to 6 days. So about 5 days from the time you get infected to the time you start to manifest symptoms. But as I mentioned, you have high viral loads and you can actually transmit infection before you have symptoms. And again, that's why it's so challenging to deal with. You're hearing, no doubt, in the newspaper about all kinds of unusual presentations, including vasculitis, particularly in kids, a Kawasaki's-like syndrome. Kawasaki's disease is an inflammatory disease of arteries, can present with heart problems, fever, rash, mouth sores. But these are actually really unusual. You've heard about strokes and pulmonary emboli. Yes, it definitely happens, but the vast majority of people are presenting, if they have symptoms, with fever, cough, trouble breathing. An unusual presentation has been a loss of sense of smell or taste, sore throat. What we don't see a lot of is runny nose. So COVID-19 does not seem to cause a typical runny nose that a lot of respiratory viruses do. Diarrhea and GI symptoms have been reported, but again, that's uncommon, about 15% of patients. Most people will have mild to moderate disease. What do we mean by that? We mean they don't have to end up in the hospital and they will eventually get better, but it is a prolonged course. People tend to be sick for about 2 to 3 weeks, and I'll talk a little bit more about that when we get to testing. About 14% do end up in the hospital. Those are people who tend to have elevated respiratory rates. They have decreased O2 saturations, and in about 6% end up in the intensive care unit, the vast majority of which end up requiring some kind of either high flow oxygen or mechanical ventilation. We do and have used ECMO for patients in general. If you end up on mechanical ventilation or ECMO, then you have a much higher mortality rate. In one report out of New York, the mortality rate if you ended up on a ventilator was 88%. Here in California, it's lower. Our rates are running around 15%, but if you're very sick, high mortality rates associated with this virus. The median onset of shortness of breath about 13 days, and that's actually really important because we've seen a number of patients who seem to do relatively well for about 8 to 12 days, and then all of a sudden they decompensate. They have a lot of trouble breathing, and so you need to watch patients infected with COVID-19 carefully. You know, you should check in with them daily, make sure they're doing all right, because they can decompensate very, very quickly and have severe respiratory distress. And the few tragic cases we hear of younger individuals in their 30s and 40s dying of COVID-19, that's often the story. They seem to be doing pretty well, and then the next thing you know, they're they're dead. So you're not out of the woods after about 10 to 12 days. You do want to, if you're taking care of COVID-19 patients, check in on them, make sure they're okay. Any concerns about their respiratory status, get them into a hospital, an emergency room, a clinic where you can check their O2 saturations, because they can be doing relatively well, not realizing that they're breathing rapidly at a rate of 30, or you put an pulse oximeter on them and all of a sudden you find their O2 sat in room air is running like 85%. So you do want to keep an eye on them. As I mentioned, these are long hospitalizations. We've had some patients in the hospitals, including ICUs, as have others, for several weeks. In this one study out of China, the average hospitalization was 22 days and about 19 days to the average time to death. So these patients are sick for a while. Single most important factor is age. And in this sense, SARS-CoV-2 or COVID-19 is behaving somewhat differently than influenza and other respiratory viruses, which tend to hit both the very young, neonates, and infants, and the very old. So while we've all heard about the tragic case of the 3 deaths of children in New York, in fact, that's very, very uncommon. So as of May 8th, for the country as a whole, where the CDC had data on age, only 9 of the 37,000 deaths that they had age data on were in individuals under 14 years old, or 0.02%. So very uncommon to have young people die from this disease, but they certainly can get it and they can get sick, and it's not zero. And only 8% of deaths have occurred in people under the age of 55. In contrast, if you look at the hospitalization rate for individuals 65 or older, it's 160 times higher than for adolescents, and it's basically about 8 times higher, 7 times higher than for people under the age of 50. So age is a very important risk factor for both serious disease and death, and part of why there's so much focus on trying to protect our older individuals. Other things are comorbid disease. So at least among adults, less than 10% of hospitalized patients have no comorbid conditions at all. The most common ones being hypertension, obesity, and diabetes. In kids, in contrast, however, 42% of pediatric cases requiring hospitalizations did not have a comorbid condition. The 2 biggest ones are obesity and asthma. Asthma is about 12–15% of hospitalization. Men are more likely to be hospitalized and to die than women. We don't understand why. And as you've probably heard on the news, African Americans are more likely to be reported as cases, to be hospitalized, and to die than whites or Asians. We're also seeing higher case rates in Latinos than we would expect just based on population numbers alone. And we can talk a little bit in the question period about why that might be happening. So how do we diagnose them? We focus on 2 major kinds of tests. The first kind are pathogen-based tests. So here we're actually looking for either a piece of the virus or a piece of the virus genome. The most common test that you've heard of is a nasopharyngeal swab that's using polymerase chain reaction. So what we're actually trying to do is amplify the genomic material of the virus and then detect it. And you can do that off of swabs. You can do it off sputum, stool, saliva. You can actually do it off blood as well, but extremely difficult to do. We don't tend to do that well. The FDA actually just released and approved an antigen-based, home-based saliva test. So there you're actually looking for a viral protein. Think of it like a pregnancy test. You have a strip that has antibodies that can recognize the protein. If the protein is present, it binds to the antibodies. You have some kind of marker that changes color, so you get a strip or whatever, and then you have a positive test. If you look at sort of the timeline of infection, you get infected. First, you have presence of the pathogen, in this case, the SARS-CoV-2 virus. And so the tests that we're using to diagnose acute infection are these pathogen-based tests. So they're NP swabs, we're looking for the PCR, or we're looking for the protein. Those tend to occur early on. And it actually takes time to generate an antibody response, this curve being IgM, which tends to start sooner and then taper off. This test is IgG. So that's the second major group of tests. These are blood-based, plasma tests, serology tests, also known as serology. Those are not tests that we use to diagnose acute infection at this point, but rather they're tests that we use to see who has been infected and who might have protective immunity. So this is a study that actually is available but has not been published in the peer review literature. They looked at 1,300 people in New York with COVID-19 symptoms. And what they found was that the PCR test could remain positive for 3 to 4 weeks after individuals had gotten better, the longest being 28 days out, you were still PCR positive for antigen. We don't know what that means. We don't know if the fact that individuals remain PCR positive means that they have contagious virus. And there's a study going on in Korea to look at that. And the preliminary data suggests that no, it does not mean they have infectious virus. But the important take-home message is we can't necessarily use our PCR tests as we have been using to try and document clearing of infection. So one of the things that we've been doing in hospitals is we've been requiring 2 negative PCR tests 24 hours apart to take someone out of isolation. And in fact, what we're finding is we can't do that because these people can remain PCR positive for a long period of time. The second thing we learned about this is that it takes a while to generate the antibodies. So about 40% of patients, when they were tested, even though they were 3 to 14 days after their symptoms resolved, still did not have antibodies. But essentially, almost everybody who had documented PCR-confirmed COVID-19 disease generated antibodies, usually about 3 to 4 weeks after symptom onset. So does it take a while to generate those antibody responses? It looks like just about everybody does do that, but we cannot, at least right now, use our antibody test to diagnose acute infection. What else do we use? So obviously X-rays. We do not use CT scans to the extent that they do in China and other cases. This is because of risk of nosocomial spread of infection and the problems with trying to decontaminate CAT scans. So at least in our hospitals and in most hospitals in the US, we've been relying on chest X-rays. These are data from China where they do a lot more CT scanning. Most people have what we call are these ground glass appearances on the chest X-ray, often bilateral, often multilobar. And you can see them even in individuals who are relatively asymptomatic. Another important finding is lymphopenia, even in the absence of neutropenia. So you can have a normal white cell count, but the lymphocyte counts are low. And in patients who are sicker, we tend to see elevated inflammatory markers, especially CRP, D-dimers, and LDHs. IL-6s are very useful, and we'll talk about them when we get to treatment, but it's actually a difficult test to get. Usually takes many days to get the results back, so we tend to rely more on things like CRPs, which are easier to get. to get in the hospital to try to get a sense of how our hospitalized patients are doing. If you're following patients on the clinic or at home, you don't need to be following these blood tests. What you really want to be focusing on is their respiratory status and maybe a pulse oximeter just to check their O2 sat. But in the hospital, where we're worried about these patients who will develop what is called cytokine storm, where they can then become acutely ill and require ICU care for multi-organ failure, especially adult respiratory distress syndrome or ARDS. We use these inflammatory markers to try and help us understand which patients are at risk for that to happen. The big risk factors tend to be age. D-dimer is looking like it might be a useful marker to follow on our hospitalized patients, not on our patients in the clinic or being treated at home. Where do we stand at treatment? You probably heard that within the last week or so, remdesivir was approved by the Food and Drug Administration under what's called an emergency use authorization. So remdesivir is the only FDA-approved treatment that we have right now for COVID-19 disease. And we can broadly think about treatments for COVID-19 into those that are targeting the virus, so antiviral treatments, just like we use for hepatitis C or HIV, and immune modulating treatment. So let's start with the antiviral treatment. So remdesivir interferes with RNA translation and transcription. So it's working as a chain terminator. So it's that first step, if you remember the graphic where the RNA comes out and it's got to be transcribed to create the DNA that then is going to make the protein. That's where remdesivir works. It blocks that step. We have not yet seen the trial results of the NIH-sponsored trial of about 1,000 people, but the preliminary results suggest that it shortens hospitalization and symptoms by about 4 days. It was statistically significant. There was a suggestion that there were fewer deaths in the remdesivir arm compared with the placebo arm. That was not statistically significant. Remdesivir is actually continuing to be used in a trial now with a second agent to see whether or not adding a second agent will improve remdesivir. So that's the only actual COVID-19 specific treatment that we have available to us. And in fact, we don't actually have it available. There's an extreme shortage of remdesivir in the country right now. It's a very difficult molecule to synthesize. And so unfortunately, it may be difficult for people to get access, at least for the next couple of months, until Gilead can increase production. Among the non-FDA improvements that are under study, you've probably heard a lot about hydroxychloroquine. I'll just say that at the moment, the evidence so far is no clear benefit, but again, being studied because at least in vitro in the laboratory, it does seem to be quite active against a number of viruses, including COVID-19. But in vitro, we'll have to wait and see. There was a study published in China using lopinavir, ritonavir. It didn't seem to work. This is Calatra, a medicine we use to treat protease inhibitor we use to treat HIV. There's a more recent study out of Hong Kong combining lopinavir, ritonavir with interferon and ribavirin, which seemed to suggest benefit. That's under study. Favipiravir is actually an influenza medicine that's available in Japan. Selinexor is a medicine used to treat multiple myeloma that also has some antiviral activity. All of these are under study. None of these should be used in patients probably with mild or moderate disease, and unless you're doing them within the setting of a clinical trial, because at least at this moment, no clear evidence to suggest that they're more beneficial than harmful. The last one that everybody's been hearing about is convalescent sera. taking patients who are recovered from COVID-19, separating out their plasma, getting the antibodies, and injecting the antibodies into individuals with severe disease with the hope that that will help to modulate the infection. We have done that for a number of diseases in the past. Diphtheria was probably one of the most famous ones, led to the Iditarod and the Balto movies and all of that. That was all diphtheria toxin they were bringing up to Fairbanks for the outbreak. That's just antibodies. That's what diphtheria toxin was. We'll have to wait and see, but I think there's a lot of excitement and hope that convalescent sera will be helpful. The other major group of treatments are treatments that don't actually target the virus itself, but rather target the immune response. As I mentioned, a subset of patients who are hospitalized will develop what we call the cytokine storm, which we believe is an overwhelming immune reaction that can cause damage to a number of organs, particularly the lungs, causing ARDS. And so we're studying a variety of ways to essentially shut the immune system down or slow it down to try to prevent that cytokine storm from happening. Most of the drugs have been repurposed from drugs that are either used for cancer treatments or have been used for autoimmune diseases like rheumatoid arthritis. So, for example, the IL-6 blockers, tocilizumab has been used for cytokine storms associated with CAR T-cell treatment in cancer patients. The JAK or the JAK inhibitors, both of these drugs have been used in rheumatoid arthritis and other autoimmune diseases. And then leronlimab is actually a drug that's approved for HIV infection. CCR5, you may remember, is the HIV receptor, and it blocks this receptor, prevents trafficking of T cells. Again, basically what all of these have in common is just trying to slow the immune system down with the hope that we minimize the damage that the immune system is causing that can lead to organ damage. Steroids generally are not used except in people with ARDS, and as I mentioned, interferon has been tried alone, not beneficial. One study in Hong Kong suggesting maybe combination with lopinavir, ritonavir, and ribavirin could be a role there. But again, these are all just for severely ill patients in the hospital. Would not use any of these in outpatients, even with proven COVID disease. Finally, we're doing supportive care. Oxygenation is critical. Pressure support. You may have heard of prone ventilation, lying people on their stomach trying to open up their lungs. A number of COVID patients who are severely ill develop acute kidney injury. We try to tie them over. We have not seen a lot of secondary bacterial infections, knock wood, so far, but antibiotics, if we believe they're there. As I mentioned earlier on, reports of blood clots and strokes. Everybody gets prophylactic anticoagulation, but we do not give therapeutic anticoagulation in the absence of a documented blood clot. So how do we protect ourselves and keep this all from happening? Well, we've been hearing about this in the news for what seems like ever, but actually it's only been a few months. Critical to any outbreak is case identification. If you cannot find the cases and identify them, you cannot control the outbreak. So the fundamental single most important thing is case identification. And that's why you hear everybody talking about testing, because if I see a patient, I cannot tell you what respiratory viral infection they have unless I can test for that virus. So I cannot clinically distinguish an influenza infection from a COVID-19 infection from a respiratory syncytial virus infection. Testing is critical. So case identification associated with isolation. So the difference between isolation and quarantine is isolating is what we do with people who have disease. So if I test someone, they're COVID-19 positive, I put them in isolation until they have recovered for at least 3 days afebrile or 7 days from the start of their symptoms. Quarantine, in contrast, is what we do with asymptomatic people who we don't know whether or not they have disease. So the ship comes into the harbor. We don't know if anybody has infection on the ship, but we don't let anybody off the ship because in case they have infection, we don't want them to spread. That's a quarantine. So that's the difference between a quarantine and an isolation. Isolation, people we know have infection. Quarantine, we don't know. You may or may not have infection, but we're still going to make you stay in place. Contact tracing is exactly what it sounds like. It's you test someone, they're positive, you find out who they've been in contact with, you go test them. Hopefully, anyone who tests positive, you find them early, and then you put them also in isolation to try to stop the spread of the outbreak or the pandemic. You've heard a lot about physical distancing. Remember, those respiratory droplets travel about 3 to 6 feet. That's why the physical distancing is so important. So when that person coughs or talks or sneezes and those droplets are released, if you're farther away, they're less likely to land on you and have you get infected. Hand washing, because remember those droplets can land on surfaces. You touch the surfaces, you touch your mouth or nose. So we do two things. One is we want to use disinfectants, keep our surfaces clean. And the other is we want to be washing our hands. The role of masks and facial coverings is to stop those droplets from getting out. So it's not to keep the droplets from getting into you if you're not infected. It's those asymptomatic infections. When people talk or cough or sneeze, instead of those droplets going out into the air, they get caught in the mask. So that's the key part there. And vaccines, you know, I can talk a lot about vaccines, but I'll just say at this point, I don't think we're going to have a vaccine for about another year or so. But if there's time in the questions, I'll be happy to go into more detail about vaccines. And then I'm just going to skip over that. Apologize, that went a little long, a lot of ground to cover, but I'd be delighted to answer any questions you may have.
Great, thank you so much, Dr. Brewer. This is so interesting. I know you probably weren't looking at the chat as we were talking, but we got a lot of people.
Oops, Martha, you faded out.
Okay, sorry, it kicked me out. Can you guys hear me?
Yep, we can hear you now.
Apologize about that. I don't know what happened. My phone kicked me out. So, okay, anyways, very interesting, very informative. So thank you. We really appreciate it. I know a lot of people may have to go at 10, so I'll be mindful that that's possible. But Dr. Brewer, do you have like 10 minutes to stay?
Yeah, no, I apologize. I went longer than I was hoping to. I could have been paying more attention to the time, but I can stick around for 10, 15 minutes and answer questions. That's not a problem.
Okay, great. Thank you so much. That's helpful. So if anybody needs to leave, obviously feel free. And I will send out the evaluation and Dr. Brewer slides by email. So thank you for participating if you have to go. Otherwise, we'll go through some questions. So we have a couple for you. The first is, what are your thoughts on the transitioning out of the stay-at-home orders? Is it too soon?
So I think the critical issue there is how much have we built up our public health and healthcare capacity? So stay at home is really not the primary way that you want to control an outbreak or pandemic. The way you want to do it is through case identification, isolation, and contact tracing. So if we're now at a point where our public health departments feel that they can do that sufficiently, then transitioning out of the stay at home will be, that's probably an okay thing to do. However, I would recommend people still follow the physical distancing, the using the facial covering, because as we transition out, case numbers will probably rise. We've seen that happen in other locations as they've transitioned out as well. And we don't want to overwhelm either our public health or our healthcare capacity as we move out.
Okay, great. Thank you. That's helpful. I think everybody's a little bit nervous about how that's going to go, so that's useful. Thanks.
Sure.
Our next question that we had was, why does it take so long to create the preventative vaccines, and does this process take longer to create if the virus is an RNA virus?
So the answer is not necessarily. So there is an RNA virus, HIV. We've been working on a vaccine for 30 years. We still don't have it. It has to do with a couple of things, but the single most important thing about having an effective vaccine is what's called neutralizing antibody. So if you can generate neutralizing antibodies, you will have an effective vaccine. That's why we have such a good vaccine for measles, because those antibodies will bind with measles and prevent it from causing infection. That's why we don't have an effective vaccine for HIV, because as far as we know, there are no neutralizing antibodies for HIV. So the critical question will be, can we identify parts of the virus where antibodies bind and actually neutralize or prevent the virus from infecting cells? If we can do that, we will have an effective vaccine. If we can't do that, we won't.
Okay, thank you. Let's see, next question, little different. Do you have any tips for how to explain COVID-19 in terms of, in like layman's terms for clients, specifically why it's so important to stay home or why we should socially distance?
Sure. So what I would explain to my patients or families or friends is that this is an infection that can cause very serious disease. And by very serious, I would say somewhere between 20 to 60 times more deadly than typical influenza. And so even if you are healthy and you don't think you're at risk for serious disease, you could get this infection and transmit it to a loved one or a colleague or a friend who would get serious disease. And so together, what we want to do is we want to protect each other, particularly those individuals who are more at risk if they get infected of ending up in the hospital or dying. And we all know people like that. We all have mothers or grandmothers or grandfathers or older colleagues. And so really what you want to tell them is, if people with heart or lung disease or older individuals get this infection, it can be really serious. So we want to all do our part to make sure we don't spread the infection to them.
That's great. Thank you. I think that will be really helpful for a lot of the people on the call to be able to explain it. So appreciate that. Thank you.
Sure.
Next question, you touched on this a little, and I think this would be interesting to get into a little. It says, when looking at the numbers for African Americans or Latinos, are we seeing a correlation between the virus and biology, or should we be considering the social determinants of health and how that impacts an overall health of these populations?
So terrific question, and the answer is all of the above. So yes, COVID-19 is exacerbating the structural inequalities that have existed in the United States for centuries. So African Americans are more likely to live in poverty. They're more likely to live in crowded urban areas. They're less likely to have access to health care. If you go on the LA County Public Health website and you look at mortality rates from heart disease, for example, and just compare West LA and South LA, huge differences. If you compare West LA and Antelope Bay, huge differences. So we know that poverty is associated with disease. African Americans also unfortunately have higher rates of obesity and hypertension than whites or Asians. So it's a combination of all these factors, but the social determinants and the structural inequities are clearly a big piece of this as well. And COVID-19 is just making it all worse.
Thank you. That's interesting. This one I don't know if you'll have a great answer for, but it's an interesting question. Why weren't we ready for this type of thing, but we always seem to be ready for war? Do you have any ideas about that?
Because we have to keep learning these lessons over and over again. So every country, essentially every country in the world, developed a pandemic preparedness plan after SARS in 2002, 2003. So the United States actually has a pandemic preparedness plan. You've probably never heard of it or seen it. LA County probably has one as well. And in fact, they do exercises around pandemic preparedness. In fact, the current administration did one a year or two ago, and they did one under the previous administration as well. Unfortunately, we chronically underfund public health at every level. So we underfund it at the federal level, we underfund it at the state level, and we underfund it at the local level. And we tend not to think about public health until something like this happens. And that's exactly the wrong time to be trying to build your public health system, right? So you don't want to be trying to build your public health system in the middle of a pandemic. You want to be building it beforehand. But when budgets are tight, if you're not in the middle of an outbreak or a pandemic or some other kind of public health crisis, and it doesn't have to be an infection, you know, the contamination of lead in Flint, Michigan was a huge public health crisis, not caused by an infection. But if you're not in the middle of a public health crisis, you tend to forget about public health, and it tends to be one of the first areas of government to be cut. And somehow we have to convince both our population and our politicians that public health is actually important and needs to be supported even outside of crisis periods.
Oh, that's a great answer. Thank you. Okay, and then we just have a couple more. So one, if COVID-19 mutates, what does that mean for the vaccine?
So all RNA viruses mutate, and most of the time those mutations are not important. They do not affect either the transmissibility or the immune response. So remember, measles is an RNA virus, and yet we don't have to get measles vaccines every year. It's going to depend totally on where the mutations occur and where the antibodies bind. So that spike protein on the coronavirus that binds to the receptor, that tends to mutate more than other parts of the virus. So if the neutralizing antibodies, assuming they exist, bind to that spike protein, then we may be in a situation like influenza where you have to get a vaccine every year or every couple of years. If the neutralizing antibodies bind to a part of the virus like they do in measles that does not mutate much, then you may only have to get a vaccine once or twice in your lifetime to be protected. So RNA viruses mutate. Most of the time, you don't have to worry about those mutations. And in terms of a vaccine, it's just going to depend on where the critical antibodies bind.
Got it. Okay, thank you. Okay, and then what do you think about the antibody testing? And do you think people should go get the test to see if they were asymptomatic?
So at this point, I would hold off just because there's high variability in the quality of the tests that are available. So in the understandable rush to get testing out, the FDA allowed a number of tests to go out on the market without the usual kinds of requirements to make sure that the tests are accurate, that normally have to be in place. And I think one of the things that we're seeing and you're reading about in the news is there's variability in the quality of the tests that are out there. So if you're asymptomatic, I would probably wait and allow some of the tests that probably are not as accurate as they should be to hopefully get either better, improved, or taken off the market until we have a better sense that the tests are more accurate. There are accurate antibody tests out there, but it would be a little difficult for any of us to know which ones without understanding the characteristics of the test.
Okay, great, thank you. I think I'll do one more, and it's I think a good way to kind of wrap it up because it's looking forward and what we can do. So how do we protect ourselves best in an office setting or doing telehealth visits next to coworkers?
So what you're going to want to do is you're going to want to try to maintain that physical distancing as much as possible, that 3 to 6 feet. Another thing you can do is you could put barriers between people, right? So viruses don't go through walls. If you could put some kind of partition up, that would be helpful. Make sure that you clean your desk, your computer, your phones after use. Just wipe them down with a disinfectant wipe. Make sure that you wash your hands before you eat, before you touch your mouth or nose. And then when you're in public spaces where you can't physically distance, if you have some kind of face covering on, that will help. When you get home, again, make sure to wash your hands. So all of those things will help to protect you from COVID-19.
Great, thank you so much. I think that's a good way to end, to remind ourselves what we can do and how we can do our part to help. So I really appreciate you being willing to present this to us and help us understand it better. I think everybody really appreciated it and really found it interesting and informative. So thank you so much.
My pleasure. Thank you. Thank you very much for having me.
Of course, we really appreciate it. So I'm sure if you could hear everybody, they would all be clapping and cheering, but everybody's muted. So thanks so much, and have a great rest of your day, everybody. Thanks, Dr. Brewer. I will get the slides and send them out, and we will we'll be in touch. Thank you again.
Okay. Take care. Have a good morning. Bye.
Thank you, you too. Thanks, everyone.